Okay, let's talk about something you've probably seen, but maybe never really thought about. Central catheters. You know, those thin, flexible tubes that give doctors a direct line into the body? They are, and I mean this, one of the unsung heroes of modern medicine. For patients who need long-term treatments, these things are absolutely essential. They save countless lives, every single day.
So just how common are they? I mean, really? Well, take a look at this number. Over 5 million of them are inserted in the US every single year. That is just staggering. That's 5 million lifelines delivering everything from fluids and critical nutrition to chemotherapy and powerful antibiotics. They are, without a doubt, completely indispensable.
But, like any powerful medical tool, there's always a catch. They carry a hidden risk, a complication that often flies under the radar, but it's becoming a bigger and bigger deal as we use them more. So what exactly is the downside to such a vital piece of equipment?
And that brings us right to the heart of what we're talking about today, a condition called upper extremity DVT. Let's break down exactly what that is.
Okay, so upper extremity deep vein thrombosis, or UEDVT for short, is basically a blood clot, and it forms in one of the major deep veins of your arm, neck, or chest. The best way to picture it, think of it like a traffic jam, but happening inside a vein. The catheter is kind of like a car parked in the middle of the highway. It's a foreign object, right? It can mess with the smooth flow of blood, causing it to slow down, pool up, and eventually form a clot, which we call a thrombus.
And listen, this isn't some tiny, insignificant risk. This one autopsy study just lays it out in plain, stark terms. In veins without a catheter, the risk of a clot, just 1.6%. Pretty low. But look what happens when you put a catheter in that vein. The risk shoots up to a staggering 36%. That's a massive, massive increase. It really shows that the device itself is a major trigger.
Now, I know what you're thinking. A number like that sounds pretty alarming, and for good reason. And it's true, studies do show higher mortality rates in patients who get these clots. But, and this is a really important but, we have to understand why. This quote here really clarifies it. It's typically the patient's severe underlying illness. We're talking about things like cancer or a major infection. That's the real driver of mortality, not necessarily the clot itself. It's a serious complication for sure, but it's happening to an already very sick person. All right, so if this is a known risk, you'd think we'd have a straightforward way to spot it, right? Well, that's where we run into one of the biggest challenges with UEVDT. I mean, what are the warning signs you'd expect? Probably some obvious swelling in the arm, right? Maybe some pain or redness. All of those seem like pretty logical signs that something's not right inside a vein. And this is where it gets so incredibly tricky. The single most common sign of one of these clots is absolutely nothing. No symptoms at all. In a huge number of cases, the condition is completely silent. And this study of cancer patients, who are already a high-risk group, shows exactly what I mean. Just look at these numbers. Only 12% of the patients who actually had a clot had any symptoms. But look at this other slice. 29%, more than double, had clots that were completely asymptomatic. The clots were there, but the patients had absolutely no idea. So, okay, even though a lot of these are silent, symptoms can show up. And when they do, these are the classic signs you want to watch for. We're talking swelling in the arm, neck, or chest, pain or tenderness, redness of the skin, and sometimes you might even see the veins on the chest wall get really noticeable. That's the blood trying to find a detour around the traffic jam.
So why is it so important to catch this even if there aren't any symptoms? Well, here's the really serious part. In about 5 to 20% of cases, a little piece of that clot can break off, travel through the bloodstream, and get stuck in the lungs. That's called a pulmonary embolism, and it is a very, very serious and potentially life-threatening event.
This really just hammers home how important awareness is, right? Knowing who is most at risk is the absolute first step toward preventing this or catching it early. So let's dive in and decode those risk factors.
You can basically sort all the risk factors into two main buckets. On one side, you've got patient-related stuff. So things like if you've had a blood clot before, if you have cancer, or if you're fighting off an infection. All those things make you more susceptible. Then, on the other side, you have the catheter-related factors. This is all about the device itself and how it's placed, like the size of the catheter, whether it's inserted on the left side of the body, or if the tip ends up in a less than ideal spot. Okay, let's zoom in on the size of the catheter for a second, because this is a huge deal. This table really shows why. A larger catheter can literally block off up to 80% of the blood flow in that part of the vein. And when blood flow slows down that much, your risk of a clot just skyrockets.
You can see the dilemma for doctors, right? A bigger catheter might deliver medicine faster, but it directly increases the clot risk. It's a really tough balancing act.
And it's not just about size. It's also, location, location, location. Where the tip of that catheter ends up is absolutely crucial. The sweet spot, the safest place for it to be, is right at the junction where the main vein from the upper body, that's the superior vena cava, connects to the right atrium of the heart. Why there? Because the blood flow is super fast and turbulent right there, which acts like a natural power washer, constantly cleaning the catheter tip and making it really hard for a clot to form and stick.
Okay, so we get the problem, we know the signs, or lack thereof, and we understand the risks. The good news is there's a really well-established game plan for dealing with this when it happens. So let's walk through how doctors diagnose and treat UEDVT.
The whole process is actually pretty logical. It all starts with suspicion, right? A doctor looks at a patient's symptoms and their risk factors and thinks, this could be a clot. From there, the number one go-to tool is an ultrasound. It's super simple, non-invasive, quick, and it works really well. Now, if the ultrasound isn't giving a clear picture, especially for those veins that are deep inside the chest, then they can bring out the bigger tools, like a CT or an MR scan, to get the final word.
So once a clot is confirmed, there's a pretty clear playbook. The first-line treatment is anticoagulation. You probably know these as blood thinners, and that usually goes on for 3 to 6 months. The whole point is to keep the clot from growing and stop new ones from forming. Then, if the catheter isn't needed anymore, get it out of there. Remove the trigger. For really severe cases, where the clot is causing a lot of problems, doctors can use powerful clot-busting drugs to dissolve it fast. And finally, if a patient can't take blood thinners for some reason, there's an option to place a tiny filter that acts like a safety net to catch any pieces that break off before they can get to the lungs.
But those powerful clot-busting drugs, the technical term is thrombolysis, they aren't for just anyone. They carry some serious risks of their own, mainly bleeding. So, as these official guidelines say, this more aggressive approach is really reserved for a very specific type of patient, someone with severe symptoms, who's in otherwise decent shape, and who has a low risk of bleeding. It's all about tailoring the treatment to the person.
All right, so we've gone through the what, the why, and the how of all this. So what's the big takeaway here? What's the one thing you really need to remember?
It really all boils down to this. Central catheters are lifesavers, period. They're not going anywhere, and they shouldn't. The solution isn't to stop using these amazing tools. The solution is awareness. It's about doctors being super vigilant about the risks and using the best techniques. And it's about patients knowing what to look out for. When that happens, this hidden risk becomes a manageable one.
And that really leaves us with one final, bigger question, doesn't it? This whole challenge isn't just about catheters. It's really at the heart of all medical progress. It's this constant balancing act between incredible, life-saving innovation and the risks that always come with it. So the ongoing question for every single medical team out there is, how do we continue to walk that tightrope to make sure that the immense benefits of our tools always outweigh the potential for harm?